Mm.
Okay. Accepting gifts from patients raises complex issues. Some physicians decide to adopt. Some physicians decide to adopt a no gift policy. Others maintain that gifts of no value, given with no expectation or preferential treatment, and acceptable, or that rejecting the gift can damage the patient physician patient relationship. In the absence of absolute guidelines, most physicians decide whether to accept a gift on a case by case basis by considering multiple factor: cost, type, and timing of the gift, the warrant motivation behind giving it, and the nature and the longevity of the physician patient relationship all factors into the decision of whether to receive a gift. In this scenario, the primary concern is the patient's impaired mental status influencing her decision making. She has a bipolar disorder, and her giving, her difficulty sleeping, racing thoughts, elevated mood, excessive online spending, and a pressured speech concerning for a manic episode that have compromised her judgment. The physician must the physician that has compromised the physician must consider that this patient's gift may have been purchased with the context of diminished reasoning due to her manic state. Therefore, regardless of the cost, the gift should be politely declined while expressing appreciation for the officer. Uh, Thank you for thinking of me, but I am unable to accept this gift, and the rationale for the refusal should then be clearly explained. I am concerned your condition is influencing your decision. Okay.
27 gravida 2 para 2, 39 weeks gestation come to labor and delivery while in active labor. Prenatal health has been uncomplicated and her prior pregnancy ended in spontaneous vaginal delivery of a 3 pound, no, 7 pound infant at a term gestation. The patient has no chronic medical condition, only medication prenatal. Pre-pregnancy BMI is fine. The patient has gained like 28 pounds during this pregnancy. Patient rapidly progresses to 10 centimeters cervical dilation and begins pushing. Delivery is complicated by shoulder dystocia lasted 3 minutes, which required maternal hip flexsions or papi with pressure, delivery of the all of that. APGAR are 4 and 7. The infant exhibits a brachial plexus palsy and is transferred to the NICU. Which of the following the best way to reduce complication rates for shoulder dystocia?
Okay. This patient has a shoulder dystocia. This patient has a shoulder dystocia. This patient has a shoulder dystocia or a fetal shoulder impaction behind the symphysis pubis, And behind the symphysis, behind the symphysis pubis that impairs the delivery. Shoulder dystocia is an infrequent obstetric emergency which may be which may result in neonatal brachial plexus injury or hypoxic ischemic encephalopathy. And maternal postpartum hemorrhage complication risk factor include diabetes mellitus, fetal birth weight more than 4,500, obesity with excessive gestational weight gain. However, shoulder dystocia is highly however shoulder dystocia is highly unpredictable, making it difficult to prevent and occur even no risk factors are identified as in this patient. No risk factor identified as in this patient due to unpredictable nature of shoulder dystocia. All staff members, nurses, obstetrician require training at routine interval to refresh clinical knowledge and technical skill. Simulation based training SBT, simulation based training SBT is particularly helpful because team members can train together and gain hands-on practice using simulated practice scenarios. This approach improves team performance, rapid coordinated response, and technical skills maneuver to resolve dystocia. Scheduled SVT sessions have been associated with reduced rate of neonatal complication, brachial breaches injury, and from shoulder dystocia. Okay.
Next. 83 woman comes to office with chronic kidney disease. Lab results show estimated GFR 18. Medical history hypertension, coronary artery disease, osteoporosis. 5 years ago, the patient had a right hip fracture due to fall in her home after she rose too quickly. She can perform activity of daily living and lives with her husband, who is in good health. Blood pressure is fine, pulse is fine. Exam, the patient is alert, lungs are clear without crackles. There is 2 plus bilateral pedal edema patient can ambulate slowly with a walker. She asks, my cardiologist says my heart is stable, but my kidneys are getting worse, and I'll probably need dialysis soon. What are your thoughts on dialysis? Which of the following is the most appropriate response by the physician?
Okay. Answers are very confusing. Okay.
Mm.
End stage, end stage renal disease. Okay, I am asking you a question. Like
Mm.
a patient, features of absence seizure, and there is repetitive hand movements and forgetfulness, and sometimes there is brief post-ictal confusion. What is your diagnosis?
Absent seizures. Uh, you say
Absence
what? Absent
seizure,
seizures.
absence seizure, repetitive hand movement, and
Mhm.
forgetfulness.
Mm, is this CGD? Oh
Sorry,
no. Cross, is it Crofeld something? CGD?
Creutzfeldt-Jakob? No,
Yeah. Okay.
no. In Creutzfeldt-Jakob, there is rapidly progressive dementia, myoclonus. Isn't it the feature? Like dementia, the one of the subtype of the dementia is CGD, Prions disease.
Mm,
It is
mm,
temporal lobe epilepsy.
temporal lobe epilepsy.
In temporal lobe epilepsy, the scenario actually looks like the absence seizure, but
Mm-hmm.
the other clue in here like repetitive hand movement and forgetfulness.
Repetitive hand movement and forgetfulness. Okay. Okay.
Okay.
Okay.
Okay, end-stage renal disease. End-stage renal disease is imminent in elderly people with significant comorbidities and functional decline. The next step the next step involving counseling the patient on the benefits and the risks of treatment option dialysis versus non-dialytic conservative kidney care and asserting her goals of care. Although dialysis extends life expectancy in younger patients with limited comorbidity, that benefit becomes negligible in elderly patients with significant comorbidities and functional decline. In addition, obtaining vascular access and devoting time and transportation for dialysis increases discomfort and time away from family. Unlike younger patient, elderly patient tends to have prolonged fatigue and increased hospitalization, catheter-related infection when undergoing either peritoneal dialysis or hemodialysis, which diminishes the quality of life. Alternatively, conservative kidney care is a non-dialytic option that focuses on patient comfort and is preferred for elderly patients and or those with advanced comorbidities. In this option, low sodium diet, low potassium, and relatively low protein to minimize uh, acid accumulation and medication. Phosphate binder erythropoiesis stimulating drug are ameliorate volume used to ameliorate volume and electrolyte and acid base balance as well as anemia and hypertension. Symptoms of fatigue, nausea, and pain associated with ESRD are addressed to when patients elect to not initiate dialysis. The average life expectancy while on conservative kidney disease is 6 months to 2 years. Okay.
The parent, 16-year-old boy, called the office to discuss concern about the son's behavior. The mother reports that he has been more distant and his grades have declined over the past 2 months. The patient has no significant medical history, no medication. The parent asks if a urine drug test can be ordered without the son's knowledge. The father says we just want to get him help if he needs it. Which of the following is the most appropriate response to the parents?
Can you give me a minute? My sister is calling.
Yeah.
Okay, 1 minute.
Okay. You should be able to see my screen.
Okay, I am giving you another scenario.
Okay.
Like 64-year-old woman,
Mm-hmm.
8 weeks of back pain.
Mm-hmm.
She has like anemia.
Mm-hmm.
Uh, Anemia. ESR is high. Low back
Mm-hmm.
pain, anemia. ESR is high. He has CKD. He is on peritoneal dialysis for 2 years,
Mm-hmm.
and
Mm-hmm.
he has marked tenderness on the L4, L3, L4 vertebra, and
Mm-hmm.
she has crackles
Mm-hmm.
and chest X-ray show a cavitary lesion in the left upper lung, and
Mm-hmm.
and spine imaging show collapse on same L3, L4 area. What is your
Mm-hmm.
diagnosis?
Mm-hmm. Cavitary lesion.
Do you want? Do you need the options?
Yeah, give me options. That works.
Multiple myeloma,
Mm-hmm.
osteoporotic compression fracture,
Mm-hmm.
TB, and
Mm-hmm.
hyperthyroidism. Secondary hyperthyroidism. Sorry,
Secondary hyperthyroidism. Is it
hyperparathyroidism.
hyperparathyroidism? Is either TB or secondary hyperthyroidism? TB.
Why TB?
Because you said the cavitary lesion, and then I know TB can cause something about the spine. And then what else did you say? You said low back pain, low back
Why it
pain.
is
The
not multiple myeloma? Multiple myeloma has anemia, back
oh, you did
pain,
say anemia.
ESR.
You did say
Sorry.
anemia. You did say anemia, back pain, ESR, but then it wouldn't. The lung thing wouldn't do any. Wouldn't
Yes, the
fit there.
lung thing will not come with the multiple myeloma. Multiple
Yeah.
myeloma will come with separately, like not with the TB features. Okay,
Wait, what was the answer?
okay, TB,
Oh,
tuberculosis. You are
okay.
right.
What was it? Hyperparathyroid, whatever. Oh, it
Like,
wouldn't come with
yes, secondary hyperparathyroidism is not, it does not cause fracture or bone disease in patients with CKD, isn't it?
fracture of bone. I thought secondary can be the lung mass. Oh, but you didn't say lung mass. You said lung cavitation.
Yes, I said the cavitation.
Okay, got it.
Okay,
Okay.
so has drug testing has many clinical uses. However, patient may consider it intrusive and it risks a false positive and false negative result. In the case of adolescent, drug testing may also erode their trust of the parents and caregivers. Therefore, because of its limitation, drug testing should be considered only after a thorough history and physical examination and suggest clear indication and the benefit. In this scenario, the this patient have in this scenario the patient have a concern that their sons declining grades and distant behavior and signs of substance abuse, but mm, they have provided few details. There are many possible explanations for this behavior: major depressive disorder, school bullying. Therefore, the best approach to obtain additional information about the parents and concern and evaluate the adolescent for potential substance use or mental health in mental health needs in privacy. By pursuing more comprehensive evaluation, the treatment plan can be appropriately tailored to address identified needs and avoid missing alternative explanation resulting from prematurely assuming drugs prematurely assuming drug use as the cause. In addition, adolescents should be involved in their own medical decision and parental concern, and the prospect of the drug testing should be discussed with the adolescent. During testing, an unwilling adolescent is impractical as the patient may refuse to share the results with parents. Further, performing a test without the patient's knowledge is both unethical and illegal. Okay.
Administrators at a tertiary care hospital are interested in developing interventions to improve quality of medical care. As a first step, they wish to collect information about medical error done within the hospital. Administrators implement a voluntary web-based error reporting system, which is designed to be used by frontline personnel to report any witness medical errors or patient safety incidents. Which of the following strategies should the administrators implement for this system to function most effectively in improving safety, patient safety?
Okay. Error Reporting System (ERS), also known as Incident Reporting System, are implemented in many hospitals as a way for staff to report observed errors. Medication administration error ERS are more effective in improving quality of care when hospitals ensure structured mechanisms are present to respond to submission, including systematic procedures to investigate reported incidents. The results of the investigator should be communicated back to the reporting individual to maintain transparency and increase confidence among personnel, and their reports will result in positive organizational change. Other characteristics of the ERS: encouraging all frontline personnel who interact with the patient, not only nurses and physicians, to submit reports, established specific clear criteria for which events should be reported rather than relying on individuals' personal judgment. For example, absence of clear criteria can lead to underreporting, near miss events, errors that were caught before causing harm and should be reported in the ERS, eliminating fear of retribution associated with reporting by maintaining confidentiality and anonymity, and ensuring investigation's primary focus on system factor rather than mistakes of the individual personnel, and simplifying the report process to minimize the time and the effort required to submit a report. Can you please explain?
Mm, like what? Like the what are the error reporting
Like
system?
matching with the answer, like developing mechanisms for further individuals and responding to each submitted report, what they are focusing on.
You do you know what the incident report systems are? Like you have an idea?
ERS?
Yeah,
No.
you have. It's like an online web page um where you can go and say, okay, I noticed that a lot of doctors don't wear their gloves when when they clean a wound or something, or they don't use hand sanitizers or whatever. You report it, but it's anonymous. So the doctor cannot see, or you can see, I see that Dr. Omar doesn't wear blah, 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 blah. But they won't know it's me that said it because it's anonymous. But they will see that, okay, Dr. Omar doesn't wear whatever. So they're saying that after I submit that, they should be, after I submit that on that web page, they normally the people that deal with that take care of the web page should investigate that. So they should investigate you, make sure watch you, make sure you're wearing your gloves or whatever, and take care of that. Maybe send you like a letter saying, "Hey, Dr. Roma, we've noticed that you don't wear your gloves, whatever. Please start doing so." And then they should reply to me saying, "Hey, we took care of your. Thank you for reporting that. We took care of that thing of your report."
Okay.
So they,
First,
yeah. So not only,
yes,
mhm.
yes, you carry on.
Yeah. So not only they should tell you, they should, investigate you, but they should also let me know that, hey, we took care of that.
Okay. So
Does it make
anybody
sense?
can, yes, so anybody can do report to any doctor, but they will investigate first before giving you like any threat or before giving you anything.
Yeah, they will investigate it first to make sure what the person reported
It's
is
true or
true. I mean,
false. Okay.
true or false. But anybody can. That's why it's anonymous. Anybody can submit the thing there.
Okay.
Mhm. Next, 20-year-old woman, 40 weeks gestation, group B step positive, comes to labor and delivery department of a large tertiary care hospital for scheduled delivery induction. The membranes are ruptured and the patient asks for epidural pain management. While waiting for the anesthesiology, the labor and delivery nurse accesses bags of IV fluid, IV penicillin, epidural solution from the automated medication cabinet in the room. The bags are of similar size and appearance. The nurse attaches a bag to the patient's IV line and begins infusion, believing it's penicillin intended for the GBS. Within a few minutes, the patient experiences cardiovascular collapse and dies. It's later discovered that the incorrect bag was attached, resulting in IV administration of epidural rather than penicillin. Which of the following intervention is most likely to eliminate the possibility of a similar error?
Okay. This patient's cardiovascular collapse resulting from accidental IV administration of bupivacaine A medication meant for epidural catheter use only. Medication administration errors occur frequently. Medication administration error occur frequently and rarely result from provider negligence alone. Contributing latent factors and systemic causes include a look-alike medication, penicillin, and epidural solution, and heavy workload in busy setting, labor and delivery ward in a tertiary labor and delivery ward in tertiary care hospital, which promotes work around busy workarounds bypassing protocols to improve efficiency, such as accessing epidural medications ahead of the procedure. Human factors engineering reduces the error risk by designing systems that consider and correct for the anticipated human limitations in complex environment. HFE, human factor engineering, follow a hierarchy of effectiveness. The most effective strategy involve physicians design changes, removing the reliance on human effort for correct action. Forcing action. Forcing functions are hard stop in a design. Forcing functions are hard stop in a design or process, preventing incorrect action. In this example, designing epidural bags to be physically incompatible with peripheral IV catheters and represents a forcing function, eliminating the possibility of IV infusion even if wrong bag is selected. Computerized automation uses technology to replace human effort. To replace human effort. Automated monitoring of vital signs every 4 hours, increasing reliability and reducing erroneous variation. Comparatively less effective human factors engineering strategies incorporate physical design changes but place greater reliance on human effort. Visual cues include packaging. Visual cues including packaging or label design, alerting providers to error risk. For example, brightly colored stickers on epidural solution bag. Redundancy introduces with the re- mm, double checks or repetitive steps in a process, for example, requiring providers to scan medication barcodes in addition to visual inspection. Using forcing function, these strategies do not eliminate the possibility of error because they are vulnerable to workaround and alter alert fatigue phenomenon of decreased attention with frequent exposure to visual and auditory input. The least effective HFE strategies rely on human effort for safe function. This includes education in service training and policy, providing early access of epidural medications. These interventions still needed but are unlikely to eliminate the error if used alone.
Okay. Next. 24 bicycle courier is brought to the ED after he was struck by a car. The patient was thrown approximately like 20 feet through the air and was initially unconscious when other eyewitness reached him. On arrival, BP is low, pulse is high, respiration high, oxygen 88. The patient appears extremely anxious and in respiratory distress. When he sees the trauma team preparing supplies for intubation, the patient said, no, 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 no tube. However, soon after that, the patient loses consciousness while resuscitative efforts and trauma survey examination are going. Which of the following is the most appropriate course of action?
Informed consent is typically required prior to performing any procedure of a patient. This respects patient's autonomy, all allowing patients to make educated decisions about their own health care. A main exception to the real rule is when a life-saving procedure is necessary in an emergency and obtaining consent is not possible. Informed refusal is a negative corollary. Informed consent is a negative corollary of informed consent. If appropriately informed, patients with decision-making capacity can refuse life-saving treatment, intubation. However, this requires that the same information to be discussed with the patient as is typically discussed for informed consent: the diagnosis, the proposed procedure and treatment, and allowing the risk and the benefits and alternative treatment options, along with the risk and benefits, the risk of refusing treatment. Although this patient stated no tube, he decompensated so quickly while the trauma survey and resuscitative efforts were ongoing, mm, the that the discussion nearby for informed refusal could not be completed. In the absence of informed consent, the physician should act in the best interest and proceed with the emergency endotracheal intubation, a life-saving procedure. A final consideration in this case is that due to emotional fear or physiological brain hypoperfusion, derangement results from the trauma and or hypovolemic shock. This patient may have temporarily lacked decision making capacity to give informed consent refusal. Okay.
Okay, nice. 81 women with a history of chronic AFib and mitral valve replacement. Maintained on warfarin is admitted to the ICU due to pneumonia. The patient develops asymptomatic runs of ventricular tachycardia. A cross-covering provider who is normally based in a different unit pages the attending physician. Physician is performing a sterile procedure in another unit and asks a resident to communicate a verbal phone order to 20 MEQ of oral potassium supplementation. The resident states the order as give 20 of potassium now. The cross-covering provider enters the verbal order as give 20 milligram of vitamin K, oh, in IV now. The patient receive the medication. The following day, the INR is subtherapeutic. Oh, which of the following could have prevented this error?
Okay. Poor communication is the leading cause of medical errors. Poor communication is the leading cause of medical errors. 66% of the sentinel events are serious adverse event resulting in irreversible patient harm. In this case, communication breakdown. In this case, communication breakdown caused inadvertent administration of IV vitamin K, then oral potassium, resulting in reversal of Warfarin, yeah, induced anticoagulation, reversal of warfarin induced anticoagulation, subtherapeutic iron level miscommunication, increases with the verbal order, which lack safety checkpoints, computerized alert indicating drug interaction, abbreviation 20 of potassium K instead of full dose and drug name and indirect communication resident communications of attending's order also increase error risk. Closed loop communication like as read back technique, it is used by high reliability organization, those with excellent safety records despite high risk, to minimize miscommunication. Senior conveys message specific potassium order to receiver, cross covering provider. Receiver reports back the full interpreted message to the sender. Sender clarifies and confirms accuracy of message. So use of loop communication would have identified and corrected the miscommunicated verbal order. Okay.
Okay. 72 woman comes to office with her daughter for annual exam. The daughter says that her mother has seemed increasingly unsteady over the past year. She fell 2 months ago while getting up in the night to use the bathroom. The patient has a history of mild cognitive impairment, AFib, and has been taking anticoagulation medication for several years. She lives alone in a single-story home. Her daughter helps with meals and shopping. Vital signs are normal, BMI normal. The patient is fully oriented and remembers 2 out of 3 objects. Visual acuity 20 out of 40. Bilaterally, motor strength is mildly decreased. The patient requires extended time to rise from a chair. Gait is low but no ataxia. Reminder of the exam is normal. Blood testing, no abnormalities. The physician discusses fall prevention measures and arranges home safety assessment. The patient daughter expresses concern because her maternal uncle died due to complications following a fall and asks if anything can reduce the risk of injury in case her mother falls again. Which of the following additional interventions is most effective in reducing the risk of serious fall related injury in this patient?
Okay. Is it helps these hip protectors?
I don't know. I never seen it actually. I didn't even know they exist. I guess. Yeah, I didn't know.
Okay. Falls are a major cause of injury falls are a major cause of injury in older adults. Falls are a major cause of injury in older adults and can result in trauma, prolonged immobilization, and further decline. This patient has this patient has multiple fall risk factors, including prior fall, cognitive impairment, motor weakness, postural instability, slow gait, prolonged time to rise from chair. During Despite implementation of primary prevention strategies, exercise training, home safety assessment, patients may still experience fall. Osteoporosis screening and management, optimization of bone density have demonstrated effectiveness in preventing secondary fall complication and hip fracture. Screening measures should include clinical risk factor assessment, FRAX, bone density assessment, DEXA. Treatment-based phosphonotherapy is recommended when 10 years fracture risk exceeds 2.5%. Okay.
Okay. Next. 45 men comes to office for initial evaluation of back pain. The patient has had intermittent dull pain in his lower back for years and said that his previous physician prescribed oxycodone as needed, which was very helpful. He says that he thinks the pain is due to standing most of the day for work and shares that he owns a bakery. The patient has no other conditions. Takes no other medications, vital signs normal, physical exam normal. Treatment options include over the counter anti-inflammatory medications and exercise. Treatment option including over-the-counter anti-inflammatory and exercise are discussed with the patient. But at the end of the appointment, he says, "I'd love to bring you some cookies from my bakery next time." As a small way to say thank you. It's the least I can do for the care you're giving me. Which of the following factors is most important to consider when deciding whether to accept or decline the patient's gift?
Decision about whether to accept or decline the patient's gift are often complex and may be influenced in several factors and may be included in several factors including the nature, monetary value and timing of the gift and longevity of the physician-patient relationship and the patient apparent motivation and the exception for giving the gift. The potential impact of declining the gift of the physician-patient relationship should be considered. Hard feelings or rejection. There is general consensus that the gifts accompanied by an exception are preferential treatment and those of high monetary and sentimental value should be declined. There are some signs suggesting that the patient's motivation in giving the gift may include an attempt to influence the patient's behavior or an exception of preferential treatment. This patient reports that oxycodone was prescribed as needed and was helpful in the past. Even though this medication is not typically part of a treatment plan for intermittent low back pain, the physician, the patient expressed gratitude at an initial visit in which the patient has provided treatment plan that does not incorporate oxycodone. These actions should raise concern the gift may be effort to influence the physician prescribe a narcotic medications. The patient's motivation is the most important factor to consider because it is unethical to accept gifts motivated by the desire to influence the physician's behavior or by the exceptions or by the expectations or preferential or special treatment. The most appropriate reason to express appreciation for the gesture but decline the gift and assure the patient that he will continue to receive the same standard of care.
Next, 84 men with end stage progressive pulmonary fibrosis who has received home hospice care for 4 months suddenly begins refusing food. The patient had previously tolerated regular food and fluid intake, which his family provides daily. His symptoms of respiratory distress and pain are managed with palliative medication but have worsened over the past 2 weeks. The patient is emancipated and bedbound. The patient tells the hospice nurse that the physician that he wants to go on fast and express his desire to avoid all food and liquid. He states, I know this means I could die sooner, but I've lived a full life. I can feel that my time is near and I'm at peace. The patient family expresses grief and emotional distress. After hearing his request, the patient is alerted, fully oriented without evidence of cognitive impairment. Which of the following is the most appropriate next action?
Okay. Goals of patient care, hospice care in terminal illness. Hospice care in terminal illness include preserving patients' autonomy and prioritizing patients' comfort. Physicians with terminal illness may involuntarily cease fluid and food intake, voluntarily stopping eating or drinking to signal a symbolic readiness for death. Although voluntarily stopping of eating and drinking can potentially increase patients' physical suffering and may hasten death, it can also increase psychological comfort by promoting autonomy over the dying process. When a patient requests voluntarily stopping of eating and drinking, the physician should proceed as follows: confirm that the patient is cognitively intact, that the request for VSCT is voluntary and should not be influenced by mental illness. Counsel the patient and family members regarding possible consequences, including severe thirst and associated discomfort. Discuss alternatives to VSCT and discuss and clearly record the patient's preference for managing discomfort. Small sips of fluid, oral swabbing, ice chips, because delirium and cognitive impairment may occur. Okay.
Next, Quality Improvement Committee at an outpatient family medicine clinic is addressing extended wait times experienced by patients at the clinic. The average patient wait time from check-in to seeing a doctor is 33 minutes. As a result, patients expressed low satisfaction with the clinic services. The committee decided to conduct a root cause analysis and construct a fishbone diagram as shown. Which of the following best describes the primary purpose of this diagram?
This is fishbone diagram, isn't it?
Mm-hmm.
Okay. Quality of care and safety problems. Quality of care and safety problems often have complex etiologies with multiple contributing factor, active or latent factor. These factors can be accurately these factors can be accurately identified through root cause analysis, a comprehensive systemic process intended to identify all contributing factors leading to undesired outcome. The fishbone diagram cause and effect diagram is a visual tool during which team RCA fishbone during which team RCA discussions to organize the categories and causes errors contributing the problem. The problem of concern, like prolonged wait time in placed at far right of the diagram, mm, representing the head of the fish, and categories of the factor, staffing, organizational, operational, patient that may be contributing the problem and placed in diagonal spokes coming diagonal spokes coming off the central spine representing the ribs. Individual specific causes are listed under each representative main category representing the skills. Okay,
Okay. Mm.
so in fishbone diagram, like the side thing, what it means, like
What do you? Mhm.
in the fish there is the head and the fish bone. Head is the problem
Mm-hmm.
and the bones.
Head is the problem. Then you have not the spine. These ones, the big ones. These ones
Yes,
are the categories. So the problem is long
there.
patient wait.
Okay,
Mhm.
problem
The
is,
problem long. The wait times is long. The
yes,
patient have to wait a long time to be seen by patient. Okay, then the big ones that comes out of the spine are the categories. Is it due to scheduling? Is it due to teamwork? Is it due to the system, the web page? Is it due whatever? And then from the big ones come the small ones. Okay, if it's due to scheduling, is it due because the scheduling we book two patients at the same time? Is it due because the scheduling, um, I don't know, the scheduling web page don't work? Is it due for, and then from teamwork, the category of teamwork, is it due because the nurses and the doctors don't talk? Is it due because the nurses don't?
know how to, I don't know, So it's like the big category and then the little causes inside the big category. Does
Okay.
it make sense?
Yes.
Okay. Okay. 73-year-old man is seen in the hospital following emergent left transmetatarsal amputation. The patient has a history of chronic non-healing foot ulcers due to diabetes, poorly controlled, and peripheral artery disease, and was admitted 2 days ago with wet gangrene and cellulitis. At the time of admission, she had a fever, or is a woman. She had fever, hypotension, and altered mental status, and consent for amputation was provided by her son, who is her design surrogate. Following surgery, the patient has been stabilized with IV antibiotics, opiate medications, and appropriate thromboembolism prophylaxis. When the vascular surgeon explained his recommendation for left lower extremity angiography and possible revascularization to prevent further amputation, the patient refuses the procedure. She says, I'm too old for another operation. I didn't want surgery the first time and I don't want it now. Left angiography. Okay. Which of the following is the most appropriate next step in management of this patient?
Okay. This patient, this patient's mental status has improved. However, it is not clear whether she has fully regained capacity. She has fully regained capacity to make her own healthcare decisions. Although it was appropriate for son to act as the surrogate decision maker to consent the amputation when she was clearly incapacitated. The patient is now refusing further procedure. The most appropriate next step is reassess the decision-making capacity. Factors potentially affecting her cognition, such as and cognitive effects of delirium and cognitive effects of opioid pain medication should be considered. If the patient has regained capacity, her decision must be respected and supersede the wishes with any surrogate decision maker. The components of capacity include understanding the decision, inability, ability to express a choice, application of the consequence, treatment option including treatment, and ability to provide reasoning for decision. If the patient meets these criteria, it is her right to continue to refuse the treatment. Okay.
Okay. Next. 89 man with advanced Alzheimer is seen by his nursing home physician because he has gradually stopped eating and drinking on his own over the past several months. The patient has lost 10 pounds in the last 3 months. He requires assistance in activity of daily living, and verbal communication is minimal. The patient has a living will, which did not specify his preference on nutritional support when he could no longer feed himself. His medical power of attorney is his eldest son. Temperature is fine, BP fine, pulse fine, BMI bit low. On the exam, the patient is awake and in no distress. Heart and lung and abdominal exam are fine. Pharyngeal and neurological exam is unrevealing. Urinalysis is fine. Which of the following is the most appropriate recommendation regarding the method of nutritional support at this time? Mm, mm, mm,
Okay. So this patient with dementia and progressively lost his ability to independently feed himself as a sign of terminal stage cognitive decline that may be associated with loss of interest in food, uh, in loss of interest in food, ability to bring food in this month, and skin and skills required for chewing and swallowing. There is no evidence of treatable oropharyngeal dysphagia and neurologic condition at this point. The goal of feeding with shift toward the comfortable and measure for the patient rather than unintentional. Okay. Comfort feeding is best accomplished by hand feeding uh, and small portion of the food and water. There are patients presented with the mouth by mouth caregiver. These method facilitates eating and cues the patients to eat while providing enhanced social interaction. The dietary plan should emphasize foods that the patient enjoys, like cake, ice cream. Okay.
okay. Next, quality improvement commitment. Oh, quality improvement committee at an academic hospital is reviewing data on C-section delivery rates associated with nulliparous terms, singleton, and vertex presentations. It finds that 55% of vertex presentation involve C-section delivery, which is significantly higher than the regional average. Further analysis revealed that the rates of C-section delivery for vertex presentation vary up to 30% among the hospital's OBGYNs. This pattern of care is most closely associated with which of the following? A lot of doctors want to do the C-section, but it may have lower overall cost of care due to improved maternal higher cost of care with improvement in fetal health outcome. Higher cost of care, this malpractice litigation maybe. Ah,
Okay, bit confusing.
yeah, a bit confusing.
Higher variation in care, higher variation in care, higher variation in care of medical condition for which well-established practical guidelines uh, exist is generally associated with unnecessary use, overuse of services and lower extremity, lower value, quality of care related to costs of care. Example, evidence-based guidelines support vaginal versus cesarean delivery for most low-risk pregnancy. Nulliparous, term, singleton, vertex presentation are recommended and optimal cesarean delivery for normal term vaginal, normal term singleton and vertex presentation of 16%. However, cesarean delivery rates vary up to 60% among the similar geographical areas, even after adjusting for patient and hospital errors. Unnecessary cesarean delivery, as seen in this hospital, is associated with increased costs. Cesarean delivery is up to 50% more expensive than the vaginal delivery, and in and unimproved or worse material infection, for emergency hysterectomy infection need for emergency hysterectomy, and fetal respiratory distress, fetal outcomes. Okay.
Okay. The committee considers various strategies to reduce variation and unnecessary use of C-section delivery for low-risk pregnancy to improve quality of care. Which of the following intervention is most likely to reduce the rate of C-section at this hospital to recommended levels?
Okay. As seen at as seen at this hospital, the rates of cesarean delivery as seen at this hospital, the rates of cesarean delivery for low risk pregnancy can vary significantly among obstetricians at the time of the hospital. Evidence suggests that differences in provider practical style, suggestive decision making, and attitude and perceptions about treatment is the leading contributor to variation in clinical performance. Physicians are often highly focused on the care of an individual patients and may be unaware how their practice styles quantitatively compare with evidence-based standard. Provision of data-driven feedback of a physician's individual's clinical performance. Caesarean delivery compared to the benchmark and PARS is effective in optimizing physical practice quality, reducing unnecessary caesarean delivery, uh, in increasing physician awareness how their practice pattern from recognized standard can increase the attentiveness in decision making and promote care that is better aligned to the that increasing physician awareness how their practice pattern differs from recognized standards, increase attentiveness in clinical decision making, and promote care that is better aligned with evidence-based guidelines. Okay.
Okay, next. Okay. 65 men with knee osteoarthritis is admitted to a busy hospital due to an elective left knee arthroplasty. The operating room is running behind schedule and the patient case is delayed by 2 hours. Because of the delay, the surgeon is assigned a new operating room, circulating nurse, and supporting surgical team. When verifying this patient plan operation, which of the following practices is most recommended to promote patient safety?
Okay. In operative setting, in operative setting, the risk of sentinel events, serious errors causing patient death or irreversible harm, such as wrong side surgery, and it is increased of high risk, complexity, urgency, schedule delay, high case volume, and high case volume and use of interchangeable surgical teams and use of interchangeable surgical teams. Prevention of sentinel events requires system-based strategies that anticipate, detect, and correct errors. Timeout and site verification. Timeout and site verification are timeout and site verification procedure are critical safety practice that emphasizes team communication and redundancy. This procedure involves the following: preoperative verification of operative site and patient's identity using two identifiers by at least two providers. This process should involve the patient surrogate site marking, in which the surgeon clearly marks each operative site with permanent marker. Non-operative site should be marked because doing so may cause ambiguity. Okay, I'm
You do. Can
sorry.
you read the box?
Yes, I'm getting blank now.
Oh, you want to take a break after this?
uh, it's your wish. Okay. Pre Preoperative verification, patient's identity, operative site, and type of operation and site verified or documented by two providers performed in preoperative holding area and should involve inpatient or surrogate or two patient identifiers. Site marking, mark yes and with initials on each operative site. Do not mark non-operative site. Clearly mark with permanent marker. And surgical timeout occurs immediately prior to skin incision. Repeat verification of patient identity and operative site and site. Entire surgical team participates and all concerns are addressed. Okay.
Okay, we can take a break.
Okay.